So I'm just going to build on what was said there, and I'm going to talk about a study that we did a few years ago to look at the actual risk of postoperative bleeding following dental procedures on patients taking certain antithrombotic medications. I have no conflict of interest to say. So basically, because our study was concentrated on, due to the nature of work at that time, was concentrated on dental extractions, I just wanted to give a little background about tooth extractions. So surgical tooth extractions are actually the most common surgical procedure done in the United States, with about 10 million wisdom teeth removed annually in the US. Tooth loss affects people globally, and if we look at some figures from around 2015, about 276 million people actually lost at least one tooth during that year. So it is a global issue. It is something that is very, very common. If we're looking at the dental situation in Saudi Arabia, so I looked at the Ministry of Health statistics for last year. Last year, we can say this is quite a conservative estimate because, as we know, 2020 was quite an unusual year. But there was over 500,000 teeth extracted in Ministry of Health dental clinics and hospitals alone. This is excluding any private clinics. This is excluding medical cities. So you can see that this is dental extractions is a very, very common procedure. Now we come to where dental meets medical. So here at KFMC, we're part of a tertiary care institution, and we're really in an ideal position to gauge the impact of certain medical conditions and their associated medications on dentistry. But it's always really been our aim to try and disseminate this information to non-tertiary care settings. And I think this is more and more vital now that we're part of a healthcare cluster. If we look at the literature review, there was a literature review, and I really can't talk about dentistry and antithrombotic medication or anticoagulants in particular if I'm not talking about anything that was produced by a US dentist called Dr. Michael Wahal. So in his literature review, he reviewed over 2,000 patients, 2,673 patients. And these were patients taking warfarin. And this showed that just under 1%, so 0.8% of these patients who had stopped or reduced their warfarin for dental procedures had really, really serious complications from stopping their warfarin, from interrupting their warfarin. 22 of them had embolic complications, and there were 6 fatalities. So this is 6 fatalities for what's basically an elective procedure due to stopping medication. There's a Cochrane review, and there's several versions of this, but one looked at over 27,000 patients in their systematic review. And they compared the risk of bleeding. It was actually for orthopedic patients, but they compared the risk of bleeding with warfarin and the low molecular weight heparins. And it really didn't show any statistical significance in the risk of bleeding events. So now if we look at local professional attitudes in dentistry to antithrombotic medications, one study, which Dr. Faleh was actually one of the co-authors for, showed about 2/3 of dentists and medical personnel would actually recommend seeking a medical consultation before treating any patient on antithrombotic medication. We did another study along with Dr. Abdurrahman and Dr.sheef that we've just heard from, and this showed that we looked at dentists and some dental hygienists, local dentists, and the majority claimed to be very familiar when it was warfarin or aspirin, but when it came to the DOACs, they weren't so familiar. And when we broke it down and we sort of asked, would you be treating a patient on this medication? Almost 50%, almost half of these patients said they wouldn't actually treat a patient who was taking warfarin, which is a huge amount, and it's more based out of fear. This rises to up to 70%, almost 70%, that said they wouldn't treat a patient who was taking DOACs. So when we looked at this these results, then we realized we really needed to look at what was actually happening and whether these patients were actually at higher risk of bleeding. So our study, which was published last year, we wanted to look at the incidence of bleeding in adult patients that are receiving antithrombotic medications. And as I said, the vast majority, over 95%, had dental extractions, and the rest had minor oral surgery procedures in our tertiary care hospital in KFMC in Saudi Arabia. So the antithrombotic medications that we focused on were warfarin, Plavix, unfractionated heparin, low molecular weight heparin or enoxaparin, and the DOACs, at that time it was focused on dabigatran and rivaroxaban. Of course, now we have we have more patients that we're seeing now that are on apixaban, and we have another additional DOAC as well, which is now available. And we treated these according to our institutional protocol, which you've just seen briefly. So inclusion criteria, those antithrombotics that I just mentioned, the procedures, the dental extractions, minor oral surgery. So these included oral biopsies, dental implants, alveoplasty, bone grafts. These patients were all treated in our outpatient clinics and under local anesthesia. Our exclusion criteria was pediatric patients, and we see very, very few pediatric patients anyway taking antithrombotic medications. If a patient came to us with an INR of 3.5, they weren't actually, obviously this is for patients on warfarin, they weren't actually treated. They would be sent for bridging and medical intervention. Any patients with a history of chronic renal or liver disease, other than or other medications other than the antithrombotics that might impact hemostasis, we excluded those. And the biggest number of patients that we actually had to exclude, which made up almost half of the excluded patients, it was 21 patients, were those that didn't follow the medication protocol. So although we had said, maintain your normal protocol of taking your medication, take it up until the day of appointment, and as normal, don't stop anything. 21 of the patients decided that they would follow their own protocol and stop medication before they came. There was one patient who arrived at the ER who had a dental procedure done elsewhere, so this patient was also excluded. And there were a couple of patients who came, and during their appointment they said, yes, they had a complaint of they had bleeding, but there was absolutely no visual bleeding. We couldn't find any bleeding on examination, and these patients weren't treated with any additional measures because suturing or refreshing the wound might have encouraged more bleeding. We couldn't find any bleeding on examination. And as you might know, that in dentistry we quite often face patients who complain of bleeding generally while they're brushing their teeth, while they're rinsing their mouth. So it wasn't unusual that we would receive a couple of patients who might have complained of bleeding, but there was no actual bleeding. So if we look at the dental risk factors, now there's actually several, each publication seems to have its own risk factor. For this study that we did a few years ago, we had categorized it as higher risk or lower risk, and the higher risk would be 5 or more extractions during a single visit, not over multiple visits, or multiple implant placements, or a soft tissue biopsy of more than 2.5 centimeters in diameter. So basically this was what we were looking at. You've seen this just with Dr. Faleh in a slightly different format. But with warfarin, with patients on warfarin, we were looking for an INR test within 24 hours. And we're fortunate enough now that we have the point of care testing. Since this study, we have a point of care testing machine, so it's much easier for us to get and quicker to get INR results. The dose adjustment, if the INR was equal to or less than 3.5, there was no dose adjustment. If it was greater than 3.5, then we sent the patient for adjustment, bridging, as the physician who was prescribing the medication would deem appropriate. And again, we're fortunate that we have a very strong relationship, and there's a good cooperation between the physicians, and they're more than happy to help us and to accommodate patients and to adjust their INR to get it below 3.5. But there was only actually 5 patients that needed, adjustments. For Plavix or aspirin, there was no lab test, there was no dose adjustment. For the enoxaparin, it depended on whether it was once daily or twice daily. For the once daily, if it was taken in the morning dose would be held. If it was taken in the evening, there was no dose adjustment. For the twice daily, the morning dose would be held, and if there was no bleeding, they would take the afternoon dose. We tried to make it sure that once they had their procedure, it was at least 12 hours after their last dose. For rivaroxaban and dabigatran, for low-risk procedures, so less than 4 extractions, we did no lab test, we did no dose adjustment. We had put in the protocol that if there were higher risk procedures, then based on the GFR calculation, the medication will be held for between 1 to 5 days, and this depends on that calculation. Actually, within the study, there were no cases of patients on DOACs that needed higher risk procedures. So all of the patients that we treated actually didn't have to have any dose adjustment or any lab test. So basically, our procedure was the dental procedure would be done, patient discharged from the clinic post-procedure with written and verbal instructions. And when they returned to the clinic for the next appointment, they were asked about the bleeding incidents. Modal days for the number of days of follow-up was about 7 days. But the reason I put here the modal number of days is because of the nature of patients that we see. So we see a lot of inpatients, we see a lot of clearance patients, dental clearance patients, and we tend to see these daily. So if I would look at the mean number of days, it is lower than 7. So this is why we went with the modal for this presentation. Any who failed to follow up within 30 days, were contacted by telephone. 2 patients were lost completely to follow up with us, but we know they have followed up afterwards within the hospital. All of the returning patients were treated as outpatients with local hemostatic agents. None of the patients were admitted. Nobody had a blood transfusion, and there were no thrombotic complications throughout this study. So when we go into the results, we had 550 unique patients who came over 879 visits. Like I said, over 95% were for dental extractions. This works out at about 2,000 teeth. We had 14 patients, so 1.6%, who were reevaluated for related bleeding after these procedures. Patients taking warfarin were at highest risk of bleeding, so the chi-squared on that was 0.0001. We had 9 out of the 14 who were on warfarin. Plavix was associated with less bleeding, chi-squared again here 0.11. We found, interestingly, that women were more likely to return with bleeding. So 12 out of our 14 patients who returned complaining of bleeding were women. Considering that the mix of genders in the whole study was fairly equal, 45 to 55, it is a little unusual that 12 out of 14 of our patients were women. Again, the chi-square on this is 0.001. These were the characteristics of our patients. The majority of the patients were cardiac patients, some VTE, some cancer, stroke. Again, fairly spread out the age of the patients, with the majority being above 40. And here again, the majority of the patients, the antithrombotic was enoxaparin, followed by warfarin. Here you can see the primary measure that was taken. So this is what was done during the visit of the patient, whether they had Surgicel or suture, collar plug, sponge and suture gel foam, whichever measure they had. And you can see here clearly the number of patients, Plavix, enoxaparin, and warfarin. And at that time, when we were doing the study, still the DOACs were fairly new. So I think if
kindly
we were
2
to
minutes,
repeat,
kindly.
thanks. If we were to repeat the study, we would find that the DOACs now take up more of a number of patients. And you can see here the difference in over the years that we did the study. So basically the take-home message is it's generally safe to treat these patients. Use hemostatic agents if you have a patient who's on antithrombotic medications, and these are widely available. Most of the local hemostatic agents that we're using in the clinic are available in every dental clinic, from your basic primary care up to secondary care. If you have multiple surgical procedures, it might be worth spreading them out over several visits for these types of patients. And open channels of communication between medical and dental is very useful, especially for setting guidelines, but it's only really to be used if necessary. So, unnecessary communication. What do I do? This patient's on dual antiplatelets, for example. The cardiac surgeon might say, you can stop it, you can't stop it. But at the end of the day, if it's not going to cause an issue with bleeding, then it's really up to the dentist to take the lead and say, I don't need to stop this. So to limit the unnecessary communication. And I always think when I'm thinking about anticoagulants, I'm always thinking about weighing up consequences. And I think on one hand, you've got about a 1% chance of a thromboembolic event. And again, this is from warfarin, versus about 2%. And 2% is basically what you'll find in the literature of easily manageable return to clinic bleeding events. And I think there's no comparison when you look at it like that. And thank you very much.